Um, and then we'll have plenty of time, hopefully, for the second half of the sort of the hour. I suspect my talk will take 35 minutes, and then we'll have a round table conversation where you can either ask live or you can just tap in the chat box any of the questions you have. So I wanted to talk about structured medication reviews. But in SMR, I also thought, because of course, being a clinical pharmacologist, that's a word for a clinical pharmacologist, some medicines do rock. And actually, I think there's always a temptation to try and think when we review medications that we must be stopping them. But of course, as a pharmacologist, although I stop a lot of medicines, I also, of course, hopefully give some good pharmacotherapeutic after. So the format of the session, as I said, I'm going to talk a little bit about the subject of medication reviews in general, some of the practical problems. I'm going to stay a little bit away from the politics of medication reviews. Most of you will be aware of the political drivers, of course, pushing us to try and make the best use of medicines, the best value of medicines. I'm going to take you through a focus on prescribing, and then try and think about how, as clinicians, we can develop our own way of doing it, a way of doing structured medication review, and hopefully, of course, over the next few months, if not years, we'll all develop our own sort of SMR toolkits to one degree or another. And of course, it wouldn't be a yellow card talk if I didn't talk a little bit about ADRs. I'm very grateful that we're joined by Claire Huckabee, a bachelor, who will be able to answer some questions, both experienced in the field, of course, of primary care, prescribing and interface issues. So please send questions for them. So what are some of the practical problems? Of course, it's a slide that's shown by many. It's the work of Rachel Elliott and colleagues from the University of York, Manchester, Sheffield. It's a big piece of work that was done a few years ago that showed just the sheer burden within England of NHS, of medication errors that we have. And of course, I won't necessarily go through the figures. They're on the screen. You'll have all heard about it before. But clearly, medication errors continue to occur. After all, we are human beings. But it's about trying to avoid potentially clinically significant errors that we need to do something about. And of course, those avoidable adverse drug reactions, which are both costly, both in an economic term, but also in terms of morbidity and mortality. You can see some of the figures there. I mean, these are avoidable deaths, and we could do something about those. Indeed, it's been posited by the World Health Organization as one of the biggest global challenges we face. And they set out this ambitious scheme a few years ago to provide medication without harm, to galvanize global efforts to improve medication safety. And of course, we're nearly there, aren't we? We're getting on very closely. We're halfway through the global challenge to reduce medication-related harm by 50% in the next 5 years, with only about 2 years left. And I like these sorts of pictograms that the WHO come up with around moments for medication safety. And of course, whether we're adding, reviewing, or stopping medication, all of these are important moments for medication safety. So I think they're things that we have to consider quite carefully. I thought I'd start off with a clinical case, and this is a woman that I looked after a few years ago, a 75-year-old retired school teacher. And she spent some time on my ward. She had multiple long-standing issues. She'd had some osteoporotic fractures with obviously chronic pain from that. She'd had a horse riding accident which had caused a whiplash injury. She had neuralgic pain. So she had many causes for her pain. And indeed, when I went back in the notes from the chronic pain consultations, I saw many of the medicines that she had been actually sort of endorsed by the chronic pain team. At that point, her morphine sulfate sustained release tablets, she was on 160 milligrams twice daily, together with oral morphine solution, and also using paracetamol and diazepam. She had a few months on the ward, and this goes back a few years ago, but I remember the case well. And she'd had multiple issues. She originally came in with community-acquired pneumonia, respiratory tract infection. She developed cellulitis. She had problems from a suprapubic catheter, for which she had in because of neurogenic bladder. And at one point, she became very oversedated from, of course, widespread psychoactive drug use and opioid use, requiring naloxone. And then it became very difficult to re-establish pain control. Stormy course, but then I continued to see her in outpatients. And at one point, this is just some of her medicines that she was on. We'd managed to titrate the morphine, not very much, but she was also on prochlorperazine, topiramate. She was now taking her morphine oral solution up to 2 hourly, pregabalin, triptans and diazepam, at least 5 milligrams 3 times a day, and more when she felt like it. So she had a lot of problems, pain, she was wheelchair bound, she had difficulty eating, so she then had a PEG as well as a suprapubic catheter. Of course, she had some antimicrobial issues, and she was under the care of many different people, as we do. We split people up these days, we slice and dice them around the specialties in the hospital, across all the different professions, and she had dietitians and community nurses and neurologists and speech and language therapists, and of course me. And in summary, she was miserable, over-medicated and prone to drug misuse. What she really needed is a medication review, and if effectively that's the sort of thing that I had to do on the ward. And I continue to see her in outpatients because of this. Now, one of the problems, of course, is that she was reaching that stage of life when, of course, you do accrue diseases. And actually, of course, as somebody said, one of the problems is that you're getting old, and that actually that this is one of the issues. Of course, the population demographics are changing, and I certainly see this on my ward. The number of octogenarians is very high, and even those in their 90s, whatever nonagenarians I suppose we call them, and these are the predicted changes, as we can see from this type of forest plot stacked bar chart, is that we just see how the population is aging. And with people living longer, of course, not surprisingly, people are living longer because we are better at treating risk factors, especially smoking and hypertension. We're detecting people with early sorts of disease much better in terms of heart disease, potentially cancer, and many more people are living through cancer diagnoses now. And staggering statistic from the Telegraph, so it must be true, that between 1/3 and 2/3 of the current generations of babies born will live for a century or more. Quite staggering. And with this, of course, people have illnesses, not surprisingly. And now there are different trajectories, and I'll skip briefly over these. But of course, if people have a sudden diagnosis, such as, for example, cancer, they might do very well. They develop incurable cancer, they have a sudden decline and they die. People with long-term medical conditions may have a generally sort of moderate function, have exacerbations, perhaps acute on chronic, for example, heart failure or COPD, and they keep having this, it affects their function, and over perhaps 5 years or so, they may decline, and then perhaps an acute exacerbation might, of course, lead to unfortunate death. But what we're seeing a lot more of is this prolonged dwindling. So many people that are living with multiple diseases, often very poorly functioning, mostly frailty, potentially both physical and mental frailty. And of course, that will eventually lead to death. And it's, I suppose, this group of patients who are also those users of healthcare and those that we need to do something about. Again, we see these sorts of figures, again, slightly old, but actually, of course, as people get older, they develop more comorbidities. And because of contemporary science, where we can make more early and more precise diagnoses, but of course, actually, what we're doing is expanding disease, producing patients that perhaps they wouldn't have been on medicated before, and often causing unnecessary harm, increasing the cost, and sometimes leading to over-treatment. Our focus shifts from maybe to chronic diseases, maybe from those acute diseases we saw, and a shift from doing things once and correcting a single problem to ongoing management of multiple diseases. actually, which is quite a challenge, and many physicians, many healthcare practitioners find the challenge of multimorbidity and looking after the patients in a holistic way quite challenging. And with that, of course, comes also increasing disability, as I say, through both physical and mental frailty, with the increasing need for long-term care, where services often maybe aren't integrated. And so it doesn't need me to tell this audience really, but in the developed world, the elderly, and 65, of course, is not very old these days, but whilst it's a fifth of the population or so, they attribute most of the medications that we use in practice. And of course, this leads to polypharmacy, with many over-the-counter medicines and the increased risk of drug-drug interactions and ADRs. Now, I'm not going to have much time to talk about the sort of physiological changes sort of in the elderly. There's a whole lecture in itself on that. But of course, we need to remember both the pharmacokinetic and pharmacodynamic changes that happen in the elderly that make them more prone to having difficulty of handling drugs or drug effects on the physiology leading to pathology in the patient. So in terms of drug utilization, I pointed out with more comorbidities come increasing, of course, polypharmacy. And this is from Bruce Guthrie's group. Of course, they have a fantastic linkage system up in Tayside, and they've been able to look at drug utilization and the sort of pharmacoepidemiology over many years. And we can see that those adults dispense greater than or equal 5 drugs doubled between these years, so just over those 15 years, and that people on more than 10 drugs, again, was about one in 20 or so. And I suspect these numbers, of course, as you can see from this trajectory, continue to go up. And comorbidities make drug treatment complicated. It's interesting, and I often show a slide related to, you look at a single nice piece of nice guidance, and often it's only related to, say, the heart failure, or the COPD, or the hypertension, or the depression. But when you link the comorbidities together, and even when you look at this, and this is what people have done by actually looking at guidelines, is guidelines themselves cause potentially serious drug-drug interactions, which aren't accounted for, of course, when people are following a single guideline and a single disease process through to its treatment end. Now, if you like it poetically, and as Christopher said, we are recording this and we can share the slides with you. I found this poem, I can't remember where it came from, but the poetic treatment cascade, where there was an old lady who had an MI. I don't know why she had an MI, perhaps she'll die, but in the end, unfortunately, she had aspirin, she bled, she had an OGD, she had to be nil by mouth, she then had fluids, she developed heart failure and died. It's a poetic view of the children's nursery rhyme, but actually, we do see this therapeutic and treatment and cascade often in clinical practice. But I ask you, is all polypharmacy dangerous? And the answer isn't, probably not. Now, I can say that 25 years ago when I was at medical school, that I was taught, probably as many people were, the old definition that polypharmacy was 4 or more concurrent use of medicines. But of course, that's no longer valid. If that was the case, then I might as well just say, well, the whole ward that I've been around this morning have got polypharmacy, because of course they're all on at least that number of medicines. And polypharmacy, of course, can be beneficial. I introduced polypharmacy many times in my cardiovascular risk and hypertension clinic and in my general medical clinic. But it can also be harmful if it's poorly managed. So we have to try and think about the different definitions of polypharmacy, whether it's appropriate polypharmacy, prescribing for an individual which with complex conditions or multiple conditions where the medicine's use has been optimized, or whether it's problematic polypharmacy where the multiple medicines are used inappropriately or the intended benefit of the medication isn't realized. And this comes from Martin Duerden's, Tony Avers and Rupert Payne's King's Fund report from 7 years ago, which I think was where it started off. And I've even been known to say to the chief medical chief pharmaceutical officer himself, and I'm sure that Keith probably remembers the time when we had a little bit of an argument about this, where he used the phrase of tackling polypharmacy. And I said, please, can we put, whenever we have this, tackling problematic polypharmacy or complex polypharmacy? Because I feel that actually, if you think that you're just tackling polypharmacy, we may do a disservice. But actually tackling problematic or complex polypharmacy, as the latest guidance suggests, is really important. Obviously, we want the intended benefits of the medicines to be realized and reduce any risk that comes with polypharmacy. So this is where deprescribing, or the new art of, as I describe it, of deprescribing is important. Again, forgive me, I've used this case before, but actually this was a salient case, I think. A 69-year-old woman, I will call her Mrs. CJ, who had a background of lupus, for which she took azathioprine, gout, for which she was on allopurinol, ischemic cardiac disease 7 years before. She was on, obviously, a statin, but she was also on ticagrelor, antiplatelet, and some chronic kidney disease. She had a bit of hypertension as well. Of course, again, she was diced and sliced amongst specialties by the rheumatologist, the nephrologist, and the cardiologist, and probably asked herself, do I need all these tablets? Well, this young man, a physician, of course, in training, we'll call him Dr. Deprescribing, came along and said, well, maybe this is a deprescribing opportunity here. So he did his stuff. He sort of thought, well, actually, they haven't had gout for a long time. They probably don't need their allopurinol. Their amlodipine, they're probably very well controlled in terms of their hypertension. We can reduce that dose. We'll change their atorvastatin to simvastatin. And they've been on the ticagrelor for 3 years. And I thought only patients got that for 12 months. So we stopped that too. Can you imagine what happened? Well, the patient developed a lupus flare. Unfortunately, they ended up being readmitted to hospital and they were given prednisolone. Unfortunately, because of the pro-inflammatory state, they developed a non-ST elevation MI because of instant thrombosis. And the complications later on, the patient developed acute kidney injury, delirium, and after a 2-week hospital stay, unfortunately died. So Dr. Deprescribing obviously overlooked expert prescribing advice by these colleagues, and he just didn't know his pharmacology. I could ask people to put in the chat box if they're really bored of listening to me what they think went on, but it's not surprising that the allopurinol, the azathioprine dose was low because of the xanthine oxidase inhibition by allopurinol. So, of course, the patient needed a much higher dose. If they were taken off the allopurinol, they were much more prone to having myositis when they were changed to simvastatin as a 3A4 inhibitor. And the ticagrelor was actually intended to be lifelong. So he didn't know his pharmacology and ended up in trouble. Now, I'm not saying that all deprescribing is dangerous, but I am saying that it is difficult. And deprescribing, first described 17 years ago now, the process of withdrawing inappropriate medication supervised by healthcare professionals with a goal of managing polypharmacy or improving outcomes, has of course become the new kid on the block. A systematic process taking into account, of course, patients' status, their functioning, and their values and preferences. And this is something, of course, that maybe we don't need to call it a new name, but actually it's really important. And other things, it's not just taking medicines away, it may be reducing doses, switching to safer medications. They're all reasonable deprescribing strategies. Now, when we think about deprescribing, or actually when I thought about it, I was thinking, well, actually, it's a very good lesson to us, because of course when we start a medicine we would only ever start it if the benefit-harm balance was positive, but actually it's not positive for the whole time. There's often a time-dependent change in that balance, so that over time it might become a bit more on par, we're not quite sure, but over time then actually the risk of harm outweighs the risk of benefits. And for example, we found this recently, haven't we, with bisphosphonates for osteoporosis. We know that the MHRA put out its guidance about after 5 years, for example, there's probably there's always a risk, but actually there's a risk of atypical femoral fractures, as well as all the other risks that come with bisphosphonates, and that actually we ought to try and consider whether they should be deprescribed after a period of time. And this guide, deprescribing, and there are many different guides, is one of the guides that we can take to actually try and think about deprescribing of bisphosphonates in particular. I point, and I think in the references I put something in here, but deprescribing.org is the Montreal North American website, which they've actually got evidence-based guidance. And this group, which I think was probably the first group in the world to actually start creating the evidence basis, now have an app. And I would actually encourage people to go and have a look at some of the resources. They don't have deprescribing algorithms for every drug class, but obviously some of the more important ones. This example being benzodiazepines and Z-drug deprescribing. So stopping medications is certainly one of those moments for medication safety as advocated by the WHO. And we need to make sure that when we're doing this, that actually we enter into that conversation about what happens to the patients, and potentially also trying to make sure that we avoid inappropriate deprescribing, suddenly stopping where people may, for example, have a withdrawal reaction. And then, of course, what to safely do to dispose of leftover or expired medicines. So it is a mastery skill, and this reference points to a qualitative study which actually showed some of the challenges to rational deprescribing, the lack of the evidence base, which is developing, the lack of time and funding, chaotic prescribing environments, and maintaining relationships. And I'll briefly talk about that towards the end. So, of course, probably the reasons that most of you are here is that the new network contract for directly enhanced service for general practice pharmacy has put in the idea about structured medication reviews. As part of the medicine optimization strategy, we need to understand, and I'm not going to necessarily reiterate all the guidance this afternoon, but I am going to point to you some of my thoughts on it. Well, this is a slide I often actually tell the medical students about the important role that pharmacists have in just general medication use review, or an MUR, and obviously that we go through every drug and why it's prescribed. Is it appropriate? Is it still required? Actually, is it having its desired effect? And so on and so forth. And of course, medication use reviews have been undertaken for many decades. But the new enhanced service suggests that actually through the structured medication reviews, clinical pharmacists will support patients to take their medications to get the best from them, but also it has quite a wide-ranging implications, much more than probably just an MUR, to reduce waste and promote self-care. And so they've come up with this snappy definition: structured, holistic, personalized review of an individual who's at risk of harm or medicines-related problems because of their current medication regimen. There's a few more sentences in there, which must consider all the medicines a patient is taking or using. So I liken this to medicines reconciliation and a medication use review on steroids. You know, the real good-going hypertrophied medication review that all you pharmacists are used to undertaking. Now, there is some guidance within the documents about taking a proactive or a reactive approach. Of course, as ever in medicine, prevention is better than cure. So actually, if we can be proactive, that's quite important. So how do we choose those indicators? And I'll be interested for people's views when we go into the wider chat. Do we just pick an N number of medicines? Well, it's clearly not 4. The guidance suggests maybe 10 or more. Do we look at potentially frail patients? Do we use some sort of trigger tool? And people will be aware of the PINSA guidance. It's, of course, come out of Nottingham and that's been widely advocated. And again, many people will do that, where actually we're looking at those sort of markers of potentially medication safety within systems. Do we just take a particular demographic, such as residential or nursing home patients, or do we take people with specific comorbidities or on certain drugs, such as opioids for chronic pain, or patients on multiple anti-epileptics? All of those, of course, equally good proactive approaches. But we should also be reactive, because if people do end up with harm, or they've got very high risk as identified by perhaps another healthcare professional, the GP or carers, certainly if they've already had an adverse drug reaction reported, if they've recently been discharged from hospital, or they've had a recent hospital admission. And one thing which I thought was quite a useful thing, if somebody's obviously worried about adherence issues, and perhaps there's a request for and I put it in inverted commas, some sort of adherence aid, such as a blister pack, is that itself is a flag for potentially being reactive. I just briefly mentioned the frailty assessment. You may be aware of this, but that's certainly in clinical practice. We base this on the Rockwood Clinical Frailty Score. There's 2 scores here which haven't included 8 and 9, which are sort of bedbound and end of life care. But at the moment, actually, frailty is anything from people with limited dependence on others for daily living. Clinical frailty score of 5 or more is often quite an important indicator, of course, of potential risk from comorbidity and polypharmacy. And I'll skip lightly over this, but I'm quite impressed. The new geriatric giants, include the susceptibility to the side effects of medication. And this is important as a frailty syndrome and raises a suspicion of problems. And again, we will see this. So you've got a big job to do. And of course, as the way of saying, how do you eat an elephant, or how do you undertake a system-wide SMI prioritization process? Well, one bite at a time. You won't be able to do everything straight away. And of course, there'll probably be a mixture of proactive and reactive approaches. It'll be very interesting to hear which approach works well in different primary care networks. And so, as I sort of do, but this is more sort of in my brain rather than necessarily in person, we all sort of develop a toolkit, don't we? And of course, we have all of these things. We're given information such as medicines with limited clinical value. We've got criteria like stopping the overprescribing of medicines in patients with learning difficulties. We've got anticholinergic burden indexes. We've got drug-drug interaction checkers. Some of these are built into the systems we use. Some of them may be apps. But we have to try and find a way to, as part of the consultation, is to create the tools within our toolkit. And no doubt, again, we'll be hearing more about this as SMRs become more widespread around the country. People will be aware of tools that identify inappropriate medication use. And there's been various explicit criteria used to identify PIMS. All the way back from the Beers criteria, which are probably 40 years old now, medication appropriateness index, the Italian Geronto-Net ADR risk score, and stop-start. And I'll concentrate on stop-start, again, be well known to many of you, but Dennis O'Mahony, my colleague from Cork in Ireland, who used to work here in Birmingham 25 years ago, together with his colleagues, came out with these criteria. And they really are very good, recently updated based upon consensus validation, and identify those prescriptions which are potentially inappropriate to use in patients. But also, unless somebody's end of life, is drug therapies which should be considered to be initiated. But it's not easy, and we do this exercise actually with our pharmacy students as a practice, and we give them the stop-start criteria and take them through a patient case. And actually, it's something that does take a bit of time to do. But actually, if you've got the time, it is a very, very useful tool. And increasingly, of course, we're trying to find electronic clinical decision support ways of implementing this. They went on and they had the stop frail indication. So this is the screening tool for older people, persons' prescriptions of frail adults. And again, I think that this is quite important. We forget that actually probably those drugs which are acting over years and decades, probably in very frail individuals, for example, those who have been admitted to nursing home care rather than residential care home, have generally a poor 1-year survival prognosis. And if we do need to think about symptom control, we should really be asking ourselves, should we be prescribing these medicines at all? Example indications are shown here, but of course, many of these patients can't take their medicines anyway, and yet we say, well, we should still try and give them. And even just in the last few days, I see this a lot, and you probably do as well, is that people that have been given alpha blockers at some point because of problems with lower urinary tract symptoms, but they're catheterized. So actually, it's irrelevant to give them a muscle bladder relaxant for that particular indication, and yet lots of them stay on it with the consequent hypotensive effects. Here's the ACB score. Again, this is really important as the potentially, again, more so in the elderly, but in all patients, is that as we add in drugs with more anticholinergic burden, that we're likely to cause more cognitive deterioration. And probably one of the last tools, and of course there's lots of different things, I bring this up because of the recent drug safety update about opioid stewardship. So there's lots of different things that we should be doing. I haven't even had a chance to talk about antimicrobial stewardship, but actually opioid stewardship is really important. And I chaired the expert working group at the agency. And of course, we've now got increased warnings, but actually it's about trying to recognize the potential for addiction or dependence. And like my case that I gave at the beginning, is actually trying to recognize when people may be overusing medicines and how we can taper them making sure that we're very well aware, for example, of the opioid sort of ladder and the morphine equivalent doses. So I'm sure that's, again, an area that, following the DSU, that we'll have to try and think about much more carefully. Again, I'm preaching to the converted, because actually you'll be much better at this around dosage forms and adherence. But of course, again, bringing that into a structured medication review is quite important too. So the practicalities, of course, we're doing this webinar because of the difficulties of having face-to-face contact at the moment, you will be aware of. Of course, face-to-face is really important, and certainly doing some of my clinics remotely in patients with potentially medication problems and people with, for example, adherence problems. I find it quite difficult unless I can see them, I can have that connection with people. I can sometimes also see their physical medicines, and of course I can appropriately examine them and decide whether actually they're on treatment at all. Video consultation may also be possible, but again, that can be difficult to set up, and perhaps people that have had difficulty joining the webinar will understand the limitations of NHS IT. But we may also be able to do some remote consultation from the electronic medication record, and of course that may give us an answer, particularly with lower level structured medication review, is to do a sort of a patient absent review and try and work out whether actually they need to be seen in person or not. In the last couple of thoughts from me is that actually, of course, physician, pharmacist and patient relationships are really important. When we think about deprescribing, often this is seen by patients as a money-saving and work-reducing effort. And we know actually that it's not, and it actually creates potentially more work. And so shared decision-making, as you all know, is imperative to making this work properly. You will have to face therapeutic inertia from prescribers. I can say this as a physician, actually, is that people will say, yeah, but I want my patient on this drug. And yet sometimes we can't even persuade people that actually that they're on duplicate therapy or so on and so forth. And that actually clear communication and occasional professional challenge will be required in order to make this work. Lastly, SMR is, of course, not a fire and forget issue. We need to have an opportunity for feeding back. And of course, actually, patients themselves may come back and say, I feel a lot better since I ran out of the pills that you gave me, or I actually stopped taking those tablets. And I think not only does that allow us for feedback from our patients, but it allows us to undertake reflective practice and see whether our SMR strategy is working or not. One slide on pharmacoeconomics of SMR, because I'm not a pharmacoeconomist, but a personal view is if you look after the patients, not the pennies, the pounds will look after themselves. I think actually if we do this right, of course it will save money within the system through reduced wastage and optimizing medicines and reducing hospital admissions. So as I said, it's a yellow card talk, so we can't do a yellow card talk without briefly talking about adverse drug reactions. Please do report, particularly if you identify these as part of the SMR, report them to the yellow card scheme. Of course, any serious ADRs or those that result in harm, particularly those that are medically significant, and those are with new drugs and medicines. And of course, as we always say, if you're unsure whether to complete a yellow card for a suspected ADR, it's better to report it. We only need a suspicion. And having been on the pharmacovigilance expert advisory group at the MHRA, it really does help. We do find signals through the noise of other yellow cards or reporting very frequently, and even with common drugs that have been in use for many decades. We don't do too badly in the West Midlands, and of course, year on year, our reporting rates do go up. But actually, we, and particularly Christopher and Karamjit, have to, with myself, go to the MHRA, and we have to compare ourselves against other regions that have yellow card centres. So if we can make reports improve through the SMR and you build that into your practice, that would be great. These are just the top 20 primary care networks of which we've received reports from GPs, nurses and primary care pharmacists. Obviously, Solihull Rural PCN is doing very well, but we'd like everybody to be like that. And there were 39 PCNs in region that reported no yellow cards last year. Karam kindly provided these slides, but just to remind you, of course, that within many of the systems, particularly System 1 now, when you record a drug sensitivity for a patient, then you can automatically, it will fill in some of the details, pre-populate them, but so you don't have to do too much in order for the yellow card to go through. And that's saved as a record attachment on the patient record so that we know for next time. So if you have got yellow card reporting within the system, try and do it there, because it can actually help other people in the future. So I think SMRs are a real window of opportunity. I think that actually, one, it's a really good opportunity for us to actually get to that third global safety challenge of medication safety, but also it's an opportunity to try and help with the general economics and, of course, help our patients. And that's what's at the centre of all we do. So in summary, structured medications reviews. Remember that some medications rock. I did actually talk to one of my colleagues this morning. They said, yeah, but some medications rot, Jamie. But actually, remember that actually it is an opportunity to tackle inappropriate polypharmacy. Deprescribing isn't a necessity. It can be difficult, but they certainly are a moment for medication safety. And it's important to involve patients, carers in the shared decision making as well. ADRs may be detected during the SMRs, and if in doubt, write one out. And if we look after the patients, and the pounds will look after themselves. I provided a few reference here. Ravi Sharma gave a fantastic talk at the Clinical Pharmacy Congress, which goes in, there's an hour-long talk, very detailed about SMRs, so that's on YouTube. I put the link there. The BGS guidelines on drugs falls, I hadn't put that as part of that toolkit slide, so that's just a reference there. And the deprescribing.org from Montreal link is there. If you've got any questions or comments, obviously you can get hold of either Christopher Karamjit or myself. That's my academic email, but please do get in touch. And I'd just like to introduce my colleagues, Alima and Claire. Again, as I say, both experts in the field who are going to join me in answering any questions in the 20 minutes or so that we've got left. So please do post your questions into the chat box. If you don't, then I've got a whole list to ask Alima and Claire, and I'm sure they'd probably prefer yours to mine. But thank you very much for listening, and I do wish you all the best with the SMRs starting on the 1st of October, and look forward to potentially catching up again in future webinars around these sorts of issues in the future. Thank you. So, try and find.
Thank you, Jamie.
I'm going to stop sharing there because I can't see anything at the moment. And Alima and Claire, do you want to just briefly say perhaps a few things about yourselves for those participants? I suspect everybody knows who you are, but it would be.
Do you want to start, Claire, or shall I? Me, okay. I've been around for a really long time. I flinched when I was described as an expert in the field. I think I've just been around a long time and worked in a lot of different areas. So I've worked in community, I've worked in hospital, and then I went into primary care. So I do have some experience of sitting on the area prescribing committee for Birmingham. I worked in CCGs and PCTs in Birmingham, and now I'm with the GP Federation. And I also get to see the fascinating but slightly worrying side of when prescribing goes wrong in my role with the PDA, where we have about 30,000 pharmacist members, and we're seeing an increasing number of cases which are coming in from pharmacists, some of whom are new to general practice. So it's an exciting area, but it is an area where you need to be systematic and not stray beyond your competence. And I think I'll leave it there.
Thank you, Alima. I think when I started in primary care, you were also there. So that was 20-something years ago. So I've worked in counselling, general practice, and recently moved to our health partnership. I know most of the team are listening in today. I think it's a really exciting time for structured medication review. I think I sort of see it as a bit of a tiered approach. So you've got your MUR soon to be disbanded, replaced by DP CPS scheme, community pharmacy. You've then got your notes-based med review, and then the two tiers of med review, the type 2 and type 3, which are phone and face-to-face, I think they are just now structured med reviews, if I'm sort of trying to get in my head what the difference between all of them is. And I think the key is the holistic bit. And when Jamie was talking, I was thinking about, you know, how many of us actually look at the patient's medicines holistically? There aren't many. And it's really important that we spend time to actually talk to the patients. We've developed a template with Arden, so our team should be using a template when they're doing structured med reviews, and it's about having that reminder to do it systematically, because even with the best will in the world, you probably will forget something if you haven't got those prompts. So that's my introduction and my thoughts, really. Over to you.
So that's great. Thank you very much, both. And of course, we're having some questions coming in. I'll answer one of them from Harder, which says, is there a case for MDTs for difficult polypharmacy cases? And in fact, of course, I've thought a lot about this subject in the last week. And absolutely, I think, again, a bit like the tiers of review, this is something where the GPs will be very helpful. But actually, I have thought very carefully about how we would set this up, and I'll be interested to talk to anybody that's perhaps willing to give this a trial in due course. Claire or Alima, the next question was, can we mix and match tools to conduct SMRs? I know I have my view, but I'd like you, perhaps Claire, you could start.
So I guess it depends what tools we're thinking about. I think we've almost got to have a set method for doing this. It's got to be very, as the name suggests, very structured. So if you've got to think about what products you've got in your armoury when you're doing that review, what's the most important thing, and almost break it down. As you say, don't necessarily do it all at once. Make sure you've got a plan. So, you know, what is the most important thing to that patient that you need to solve? Are there any red flags that you need to solve first, and then gradually break it down? And you'll bring in different tools, won't you? So we've had discussions locally about what frailty scores we might use, you know, what deprescribing tools you might use. And it's making sure you've got a consistent message or approach, I think, in everything that you do, that you then tailor to that patient. Is there anything you want to add, Alima?
No, not really. I mean, you'll probably have maybe your base tool that you use, but then if you see that there are things that are going on with anticholinergic burden, then you may want to go away and look at that in more detail. But as you said, I think my key thing was have a systematic approach and use that and follow it through. As Claire said, it's easy to miss steps otherwise, and that's why I think more and more people are setting up templates on the system to prompt you. But I suppose because I'm a bit of a dinosaur, I still like looking at things like, I quite like the 7 steps from Scotland, and I quite like the way they work their way through, which is pretty similar to one of the slides that Jamie put up about, you know, the different questions you ask as you look at the basket of medicines that your patient's got.
I think the most important thing from me is if you use all the tools, you can actually, one tool can say one thing, you add a medicine, and then another tool takes something away. So it is about holistic things. And I think actually, particularly as experts in medicines, we need to take a step back and always remember that when we've done the end of the review, is actually have a look. You know, we so often see, for example, you know, I see it in practice all the time. You probably do as well. A dopamine antagonist being given to a patient on dopa agonists for Parkinson's disease. That person with 2 alpha blockers. That person with 2 non-steroidals. You know, all of these things, you know, come together. And actually, there is an issue that if you go through tools and you don't try and actually take a step back at the end and take a holistic view, you can end up in trouble. What sort of time frame should SMRs take place over? Alima, what do you think?
I don't know if we're talking about individual ones or long-term. For me, I think one of the key things to think about is that an SMR is not a one-off thing. And you don't, like Dr. deprescribing, rush in with your brush and brush out 4 medicines at once and then think everything will be all right. Whatever you're doing, I think it's an iterative process. you're probably only going to be, once you've negotiated with the patient, looking at modifying 1 or 2 drugs at a time, because you need to see then, well, have they made things better or worse? If you do 3 things at once and the patient gets worse, which one was the one that made them worse? So I think it's an iterative process. As for the time for each SMR, well, how long's a piece of string? There are so many factors that will affect that. How many medicines is the patient on? Is the general practice in? How good are they at doing their blood tests and recording them and acting on them? If your practice hasn't got lots of good framework in place and good housekeeping, then you may well find that your structured medication reviews take a good deal longer than if you were in a practice where everything was up to date and you could rely on the fact that they'd had all their tests done, their UNEs, and that everything had been actioned. In that case, you probably just have to sit down and start having a lovely chat with the patient. In other cases, you may have to do a lot of legwork. So I think it's one of those where you have to suck it and see, and it can be very variable.
Yeah, and I'm not sure whether that colleague that made the comment about timescales, of course, in 3.11 in the document, it does say that that we expect an SMR to take considerably longer than average GP appointment. You'll be pleased to know. I'm not sure how much the average GP appointment is, but I think there is a lot of ambition in here. When you sort of think about, even if they're interventions, for example, some of the the exercise, the smoking cessation. These are not, as you say, Alima, even if we tackle the medicines, we're not going to be able to tackle all these things in a very quick period of time. So I don't know if you've got anything to add, but Alima, there's one question which is very much beyond me around PDA insurance level, changing reviews, mixed messages about what they're able to do. This is clearly one for the experts here.
Right. I think this stems from the time when there probably wasn't CNSGP and most people got all of their indemnity from an indemnity provider. The PDA actually split activities down into different areas and said there's differentiated and undifferentiated prescribing. The definition there of undifferentiated is that a patient comes to you and you're the first person to see them, and they've got, I don't know, a lump. And it's up to you to decide what that lump is and what you're going to treat it with. And from an underwriter's point of view, that's one of the most risky things you can do. So the premiums are higher for people that undertake that. And that can be things like dealing with walk-in clinics, dealing with telephone triage. And I could tell some horrible stories about things we've seen where that has gone wrong. Differentiated is where you'll be looking at patients, they will already have had a diagnosis, but the patient may have come to you and they might be getting worse, or you might question, obviously within your scope of competence, that diagnosis or change it. So I'd say if you have any questions about the PDA or whoever you get your insurance from and you can't understand why they're saying there are different premiums, give them a ring, and I'm at the PDA a couple of days a week. You can always say, can you pass this on to Alima? I'll love you for it. We get lots of queries about insurance, but I think that's the key thing. How risky is the work that you're doing and how autonomous are you? And the more autonomy there is and the less prior evidence there is about what's wrong with the patient, the riskier it gets. And the more you should be thinking, am I really competent to do this? What additional training have I had? A little anecdote to explain. We had a member, they were horrifically told to do the minor ailment clinic. I don't believe there's anything such as a minor ailment in general practice unless you've diagnosed it as such. And they were far too new to have done that. But anyway, the patient came in, they came to see them for something like a cough, and they prescribed them something. And on the way out, the patient said, oh, can you just have a look at this? And the pharmacist, trying to be helpful, said, oh yeah, all right, I'll have a look. It was a lump. They treated it as an infected cyst. It wasn't an infected cyst. That patient was delayed then and ended up with a cancer diagnosis. And that's what I mean about just be careful about what you think you're prescribing and what you think you can do when you are in general practice. And if anything, if you see any combinations of drugs when you get structured medication reviews to do, it's easy when you come from community to think I'm in charge and I'm the final arbiter and I have to deal with anything. The great thing about working in practice is you don't have to deal with everything. You've got specialist nurses, you've got GPs, you've got hopefully other pharmacists within your networks, liaise, and if you've got any doubts, ask someone about it and get someone else's views. And just, chew the fat. That's one of the great things about working in practice or working as part of a team. You can discuss things.
Thank you, Alima. Somebody's added SPS, the Specialty Pharmacy Service, have super awesome SMR resources. That's really helpful. And I think that actually we should be sharing more, as people have said. So no doubt we'll have ways of doing that. Claire, I'm going to ask you a question. This is sort of Chair's prerogative. Look, like a persuasive person, we don't know each other too well, but what about this issue about therapeutic inertia and professional challenge from specialists? How do you think that's going to, I mean, you have experience of this, but actually this almost puts it in the hands of pharmacists much more to try and tackle therapeutic inertia. And what is your advice to people if they do come across professional challenge around prescribing?
Was this to me, Jamie?
That was to you, Claire, yes.
Lovely. Thank you.
No problem.
So I guess we come across this quite a lot, actually, in a variety of scenarios. I think particularly children as well, and we might face it. So I would always double check, or if something isn't correct, or you don't think that it's a routine request, make sure that that's absolutely what they want, first of all, and find out what the reason is for it. I think if you're uncertain, then even when they come back and say, yes, that's absolutely what I want, you discuss it with your colleagues, decide if it's reasonable. I would always double check what the evidence base was behind that. And I came across something the other day. It was prescribing for somebody who was going through hormonal change from male to female. So we looked into the evidence around gender dysphoria prescribing. I've come across it in the past when we looked at metolazone prescribing, which resulted in an error. And I think sometimes you only look at these differently when an error has actually happened, and you look at all the bits in the Swiss cheese that have actually lined up. But also remember, not all of these are errors. Some of them are intended, and it's reasonable based on the pharmacology that you might use drugs in a particular way. It's just not what they're licensed for. And if that's the case, you need to think about responsibility, indemnity, who's going to do that prescribing. Is it reasonable for you as a pharmacist, an independent prescriber, to make that call, or is that something that you want to discuss with your medical practitioner, and is it something they're willing to take the responsibility for? So I think there's a whole load of considerations. That was a difficult question, Jamie.
I know, I've got more difficult ones in case nobody asked them, but I think that's really important. And actually mention the word pharmacology. I think, again, one shouldn't forget about the sort of pharmacology. And actually, I think appropriate challenge is appropriately challenged according to tools, but also according to evidence-based and according to basic pharmacology, which I have to say, probably, although I'm responsible for it for many, probably doctors that qualify in Birmingham, is not always remembered, even if it was taught. We got 1 or 2 minutes left. I don't know whether I did put down the COVID challenges. We've almost got away without mentioning SARS coronavirus type 2 in the last 56 minutes or so. Any particular advice about how, the idea about how we're going to cope with SMRs, at least over the next few months or so on?
I would say that COVID has changed the way that we do everything for the good in some respects. So, we're doing a lot of things remotely, and actually a structured med review in the vast majority of cases could be done over the telephone or via a video consultation. You've got to be aware that if you're doing it that way, that there will come a time when you really need to see that patient. So it's almost being able to filter filter out who you need to actually physically see and who you need to do it remotely on. And I think that's really important. There will be some spaces in your appointment slots that you will need to reserve for face-to-face reviews.
Lima, any final thoughts from yourself?
No, I think I'd agree about COVID and doing remote. I think there are some online training and modules around how to undertake or look for the pitfalls in remote consultations and how best to treat people. So it might be worth having a look at those. But it's got to be done, and it's got to be done remotely given the circumstances we've got. And I think, again, it's just making sure you have a good system as you approach that.
Fantastic. Well, thanks very much to everybody. Just because, again, they'll tell me off, is I've got it here. Then just remember that there's an online survey. I know that Karam's been busily putting the link in, but if you could do that, they'll email you about that. And of course, because it's coming from the Yellow Card Centre, my last message is please make our figures look better. Stay in touch via our Twitter at YellowCardWM. Tell us about your successes and hashtag us in, or yes, put our note in. And as I say to everybody, thank you very much for your participation. Thank you, Claire. Thank you, Alima. We will be having a further webinar, and the Yellow Card Centre will be having one more so about ADRs and ADR reporting. So we'll keep you on our email lists. And again, thank you very much. Stay safe, everybody, and good afternoon.